are many good reasons to revisit the issue of potential risks from radiation exposure. After all, assessment of these potential risks is the very foundation upon which our radiation protection efforts are based. But the most important reason is that as a radiation worker, it's your responsibility to decide whether the health risks associated with occupational radiation exposure are acceptable to you. In this program, we're going to help you understand the information contained in Regulatory Guide 8.29 that you should consider when making your decision. First of all, just what is meant by health risk. Basically, it's something, anything, that may endanger health or safety. As you know, it's the ionizing characteristic of radiation that we're concerned with when evaluating the health risks of occupational exposures. Damage occurs when X-rays, gamma rays, or any ionizing radiation deposits energy in living tissue and damages molecules or cells in our bodies. A lot of prestigious scientific organizations have spent years studying the effects of radiation in the workplace. So, what have we learned? Just what health risks should we be concerned about when working around radiation sources? Well, we know that individuals subjected to very high doses of radiation have experienced vomiting, diarrhea, skin burns, cataracts, and even death. And we know that an increased incidence of cancer is documented in individuals who are exposed to very high doses of radiation. But what about exposure to low levels of radiation? We should probably begin by defining some terms and units of measure. And that's a little more complicated than it used to be. The International Radiation Protection Community has redefined radiation units and decided that our familiar Röntgen, Rad, Rem, and Curie didn't fit into the world view. As a result, it's been internationally agreed that the units we're all familiar with should be changed to the international system of units known as the SI system, wherein 1 Rem equals 0.01 sievert, 1 Rad equals 0.01 Gray, and 1 Curie equals 37 billion becquerels. And in the SI system, there is no equivalent unit for the Röntgen. So, during this program, we're going to use the traditional units, but display the SI equivalents like you see here. So, for example, if I should say 1 Rem, the display will indicate the SI equivalent for the Rem. All right, let's examine some terms you should be familiar with. We categorize various types of possible health effects as somatic, genetic, and teratogenic. Somatic effects are those that occur in the exposed individual. These effects can occur soon after the exposure or be delayed. Early effects, also known as prompt or immediate effects, occur within hours or days after exposure to a very high radiation dose, like 300 rads received in a short period of time. Early effects reflect extensive biological damage to cells, and this type of dose is referred to as an acute exposure. Now, if someone received an acute dose of, say, 600 rads to their hand, the effect would be limited to the skin and underlying tissue of the hand. An acute dose of this magnitude to the whole body would almost certainly be lethal. So, when setting standards for occupational exposure, regulatory agencies differentiate between whole body and partial body exposures, and for good reason. It's also important to note that receiving the same dose spread out over an extended period of time would not necessarily cause the same effects. Every day of our lives, our bodies are constantly repairing and replacing millions of damaged cells. For example, a whole body dose of 300 rads, which is 60 times the annual occupational limit, would cause nausea and vomiting within a few hours. Loss of hair, fever, and weight loss would occur in a few weeks, with about a 50% chance of death. However, these effects would not occur if the 300 rads were accumulated gradually over many years. Obviously, early effects are not a concern for occupational workers in facilities complying with regulatory agency regulations, as the doses that cause these effects are far above the regulatory agency's occupational limits. Unlike early or prompt effects, delayed effects occur years after the exposure. So rather than immediate cell damage, the problems are caused indirectly when the normal cells no longer function the same. Cancer is the major concern associated with abnormal cell development and function. Another delayed effect is cataracts, a darkening of the lens of the eye. We know there is a threshold below which no damage occurs. That threshold is thought to be a lens dose of 100 rads. We also know that an accumulative dose of 800 rads from protracted exposures over many years has also been associated with some visual impairment. Concern for delayed effects is a significant issue when occupational exposure limits are considered, and we'll address this in detail in a few minutes. Genetic effects may occur as birth defects or other conditions in future children of exposed individuals or in succeeding generations. The term may occur is important because there is no scientific evidence documenting genetic effects with human populations exposed to radiation. For example, continuing evaluations of the atomic bomb survivors of Hiroshima and Nagasaki have not shown any significant increases in genetic abnormalities. However, genetic effects have been observed in laboratory animals that were subjected to radiation. When we think about the potential genetic effects of radiation exposure, it raises another important related question. What are the teratogenic effects or risks of radiation exposure to the embryo fetus? During certain stages of development, the embryo fetus is much more sensitive to radiation than adults are. We have documentation that high doses of radiation result in an increased incidence of mental retardation and lower IQ scores. Other studies suggest that an association exists between exposure to diagnostic X-rays before birth and delayed carcinogenic effects in later life. The magnitude of these risks is uncertain. But in response to this increased risk sensitivity, a more restrictive dose limit has been established for the embryo fetus of a declared pregnant radiation worker. We will address all the specific regulatory dose limits later in the program. Another common concern is whether a worker can become sterile or impotent from normal occupational radiation exposures. Well, we know that doses of 10 rads to the testes can cause measurable but temporary reductions in sperm count. And temporary sterilization has been observed in women who have received acute doses of 150 rads. But with regard to whether a worker can become sterile or impotent from normal occupational exposures, the answer is no. While temporary or permanent sterility can be caused by high doses of radiation, there is no evidence of sterility or impotence-related problems associated with exposure allowed under our occupational limits. There are a couple of other concepts we need to understand when evaluating the risks associated with occupational exposures: external and internal exposures. Exposures originating outside the body are referred to as external, while radiation from radioactive material that has been taken into the body is called internal exposure. The intake of radioactive materials, internal exposures, is generally by breathing contaminated air, often in the form of dust from the surfaces of equipment and workbenches used during work activities, or possibly by sloppy contamination control practices, allowing the fingers to ingestion pathway. With internal exposures, the radioactive material often goes to a particular organ, depending on the chemical form of the material. Strontium, radium, and plutonium tend to deposit in the bones, where they remain for a long time. Radioactive iodine, on the other hand, is deposited in the thyroid gland. To limit the exposures to these and other organs, the regulatory approach is to establish an annual limit on intake, ALI, for each radionuclide. When more than one radionuclide is present, the amount for each is reduced proportionally. The limits for concentrations of radioactive material in the air that workers can be continuously exposed to are based on estimated exposure for an entire working year, 2,000 hours of breathing. We call these derived air concentrations, or DACs, and they are the total amounts allowed if no external radiation is received. The resulting total effective dose equivalent will not exceed the 5 rem limit. Incidentally, Our scientific evidence indicates that a rem of radiation dose has the same biological risk regardless of whether it's from an external or internal source. Another key measurement is the total effective dose equivalent, which is calculated by combining the internal and external doses. Keep in mind that these are limits for occupational exposures here, but that's not the whole story in terms of your total annual radiation dose. You're probably already aware that every person alive today, regardless of where they live or work, is constantly being exposed to various background radiations. This non-occupational exposure is from radon in the air we breathe, plus cosmic radiation from space, as well as from the radioactive materials in the earth we live on, and even from within our own bodies. Man-made exposures from medical and dental procedures also make significant contributions. As this chart shows, each of us receives about 360 millirem per year from these background radiation sources. That means that by age 20, the average person will accumulate over 7 rems. By age 50, the total dose is up to 18 rems, and by the time we're 70 years old, we will have accumulated a dose from non-occupational exposures of 25 rems. Okay, let's get beyond the terms and definitions and get to the crux of the issue, what most of you are probably wondering. We know that large doses of radiation can cause various forms of cancer, but what exactly is the increased risk of developing some form of cancer from occupational exposures? The answer is, unfortunately, that we just don't know. We, that is the scientific and medical community, just do not understand cancer well enough, in spite of all the recent advances. And it's very frustrating, because we do know that 20% of us, 1 in 5, will die from some form of cancer. Let's look at what we do know about cancer. When radiation interacts with our bodies, several events can occur. The damaged cells can repair themselves with virtually no consequences, or the cells can die. But, much like the other millions of cells that die in our bodies every day, be replaced with normal cells with no lasting damage. Or, a change can occur in the cell's fundamental structure. The cells can change and may eventually become cancerous. Many other factors can significantly affect the susceptibility to cancer, such as age, general health, inherited traits, and smoking. So you can begin to see how complex this picture is. But that's only the beginning. What you see here is called the dose-response curve, and it attempts to show the relationship between the radiation dose received on the horizontal axis and the increased cancer risk on the vertical axis. Now, above 20 rads, we have lots of data documenting increased cancers in groups of individuals who received high doses of radiation. We know that large amounts of radiation exposure causes an increased risk of cancer. The problem occurs below 20 rads, where we have never documented any such harmful effects. Traditionally, regulators have assumed that there is some risk right down to 0 exposure, and have arbitrarily extended the dose-response curve as a straight line all the way to 0. In other words, we made a prudent, safe-sided regulatory assumption with no supporting data. You might call it a scientific guess. And that mathematical assumption, known as the linear, no-threshold dose-response model, has served as the basis for our radiation protection standards for a very long time. But we've accumulated a lot of data since that assumption was first made. Let's take a brief look now at some published studies that are questioning the validity of this linear, no-threshold model. We have followed the survivors of the bombings of Hiroshima and Nagasaki very closely to determine just how many excess fatal cancers have occurred. You may be surprised at the findings. For the bombing survivors who received between 1 and 20 rads exposure, there is a decrease in the number of fatal cancers when compared to the population who were farther away and received no measurable exposure from the bombings. Furthermore, the exposed survivors are outliving the non-exposed population, and there are no excess genetic defects found in children of the survivors. We also have many studies on human populations living at higher elevations, where the natural background cosmic radiation is significantly greater. The results show that these people actually have fewer excess fatal cancers than populations receiving less background radiation. Other recent findings indicate that, contrary to what you read in the newspaper, there seems to be fewer lung cancers associated with higher indoor radon exposures. Now, as you can imagine, all this leaves our regulators in a quandary. They are responsible for making the decision as to where to set our occupational radiation exposure limits, and they have chosen to continue keeping those occupational exposures as low as reasonably achievable. In other words, regulatory agencies continue to embrace the linear, no-threshold model for estimating the excess cancers from occupational exposures. Using this mathematical model, a worker who received an additional 1 rem in a lifetime increases his or her probability of dying from cancer over and above the 20% that we all face just being alive to 20.04%. Continuing this theoretical assumption, the current average career dose for radiation workers is 1.5 rem, which may represent an increased risk of dying from cancer from 20 to 20.06%. All right, how about this question? How do our occupational risks of working around radiation sources compare to other kinds of health risks? Relative life expectancy is an easy comparison to understand. The average person who gets some form of fatal cancer is estimated to have a 15-year reduction in life expectancy. Using the NRC estimate of average occupational exposure of 0.3 rem per year, and assuming a career from ages 18 to 65, the projected estimate of life expectancy loss would be 30 days. So, even using the NRC's linear, no-threshold mathematical model, the health risks of working around radiation sources are relatively low when compared to many other risks that we face on a daily basis. For example, if you receive the average occupational exposure this year, your relative risk of developing a fatal cancer from that exposure would be much less than becoming a traffic fatality. So those of us who work around radiation sources will want to stay tuned as more information about the risks of low-level exposures becomes available and gets factored into the regulatory process. In the meantime, as a radiation worker, you should be familiar with the current occupational dose limits. Let's look at adults first. 5 rem is the current total effective dose equivalent limit. There is a limit of 50 rem to any single organ, a 15 rem limit to the lens of the eye, and a 50 rem limit to the skin or any extremity. For minors, the annual occupational dose limit is 10% of the dose limit for adult workers. For the embryo fetus of a declared pregnant woman, the dose limit is 500 millirem during the entire pregnancy. The issue of prenatal radiation exposure to the embryo fetus is significant and unique enough that the NRC has released a separate regulatory guide dedicated to the topic. Because of the specialized nature of the information and the fact that all radiation workers don't require in-depth training, a separate video will discuss this topic in detail. When considering occupational dose limits, you should be aware that medical exposures are not considered as part of a worker's allowed dose. The prescribing physician must be convinced that the potential benefit to the patient outweighs the potential risk associated with the radiation. Next question. Who gets monitored? Your employer is required by the regulatory agencies to monitor your occupational exposure if it appears likely that your external or internal exposures will exceed 10% of your allowed annual dose limit. External exposures are monitored by using individual monitoring devices, dosimeters. Internal exposures are calculated using whole body counters, along with examinations of biological samples such as urine or feces. If any worker exceeds their annual dose limit, they may not receive any additional occupational exposure for the remainder of the year, and the licensee is required to file an overexposure report to the regulatory agency. However, as you would undoubtedly infer by now, if a worker has exceeded his or her occupational limit, there is no reason or basis to conclude that they will necessarily be harmed. Remember, the current occupational limits have been established far below the doses where we have documented harmful effects. Now, there are various methods and procedures that can be used to reduce individual occupational radiation exposure. We can spread the work around by using more workers. While this definitely reduces individual exposures, it increases the collective exposure. Is that a bad thing? Hopefully, you also know the answer to that. It depends on whether we take the position that any exposure, regardless of how small, represents some level of biological harm. The current regulatory agency position is that all exposures are potentially harmful, and that the best ways of reducing risk to the workforce are to reduce radiation levels, working times, or both. As you would imagine, some facilities choose to set limits for occupational exposures lower than required by the regulatory agencies. And there are circumstances wherein facilities are allowed to exceed the annual occupational limits. These are called planned special exposures and are allowed only in exceptional situations where alternatives for avoiding the additional exposure are either not available or are impractical. With a planned special exposure, the licensees can authorize an additional dose that is equal to the annual occupational dose limit as long as the individual's total dose does not exceed 5 times the annual dose limit during the individual's lifetime. So basically, that's what you need to understand in order to make an informed decision as to what your occupational health risk is and whether that risk is acceptable. If you conclude that the risks are unacceptable, you've got a couple of options. You could request a transfer to a job that does not involve radiation exposure, or you can pursue a non-radiation occupation. However, be sure to explore the relative risks of the new job. Most radiation workers have concluded that the health risks are acceptable when compared to the occupational risks associated with many other professions. Your best method of reducing the potential health risks associated with occupational radiation exposure is to keep your exposures ALARA, as low as reasonably achievable. That means reducing the time of exposure, maintaining the maximum practical distance from the radiation sources, and using shielding whenever possible. The truth is that you have a far greater probability of being murdered or dying in a traffic accident than dying from your annual occupational radiation exposures. In the U.S. alone, we have spent billions to comply with regulations that were formulated long before many significant studies were completed. We have lots of important new data, and it's probably time for a formal re-evaluation of the risks associated with low levels of exposure. Well, once again, the decision to work around radiation sources is a personal one that each of us has to make. Hopefully, you're now in a better position to make an informed decision. Thanks for watching.